Good morning, everybody. I, Dr. Shalini, on behalf of the National Board of Examination, welcome all the DNB students watching our program across the country. Today, as you all know, we have a series of sessions in the field of practical examination in the subject of medicine, for which I have with me, sitting on my immediate left, Professor Dr. M.S. Gupta, CEO and Senior Consultant Physician, Maharaja Agrasen Hospital. To my extreme right, I have with me Dr. Anuradha Sural, Consultant Radiologist, St. Stephen Hospital. And as you all know, today's session is in the pattern of mock Viva examination, so I also have with me Dr. Neeraj on my immediate right and Dr. Shalu sitting on his right, who are DNB students from Maharaja Agrasen Hospital. Before we start with our session, I would request all our DNB students to feel free to call us on our toll-free number of 1800-11-2345 at any time in between the session. May I now request Professor M.S. Gupta to please begin with the session, sir.
Good morning, viewers. My dear students, we are continuing this as a part of our practical examination for MD for medicine DNB students. Today, the session has been earmarked for a section of the practical examination which involves Viva on various sections, say instruments, ECGs, X-rays, etc., etc. I will talk on the portion related to instruments. Now you well know that all the type of instruments which are used at various occasions for various purposes when we are treating patients of various diseases, we'll talk on those common instruments, and the common questions with each instruments are identification of a particular instrument, its indications, contraindications, safety measures, complications, differentiation, the points for identification, etc., etc. So we start first with lumbar puncture needle. So if I am the examiner and you are the candidate, we start Viva like this. I will say first identify this instrument. Now will one of the DNB students present here will respond.
So this is a LP lumbar puncture needle.
So the next question normally is, this is another needle, how will you differentiate that is a lumbar puncture needle from this needle?
So it is different from the aspiration needle because of first this needle, which is lumbar puncture needle, it has a stellate, as well as its stellate has a pin which fits into the slot of the needle.
Good. Now the next question would be, what do you mean by lumbar puncture? In other words, what is lumbar puncture?
Sir, we mean to from the lumbar puncture, that lumbar puncture, it's a aspiration of cerebrospinal fluid from the subarachnoid space.
Through the lumbar root.
Through the lumbar root.
That this is the aspiration of the fluid from the lumbar root. So it is known as lumbar puncture. Because we have alternatively cisternal puncture also when we do this procedure through the cistern. Now what is the common site for lumbar puncture?
The common site for lumbar puncture is between L3, L4 vertebrae.
Yes, normally the next question could be, why should you select the place at L3-4? The answer should be that because the spinal cord ends there and you don't hurt the end of the spinal cord. Right, good. Now the next question normally would be, what are the indications for a lumbar puncture?
So there are indications for lumbar puncture is diagnostic indications as well as therapeutic indications for lumbar puncture.
Yes.
From diagnostic lumbar puncture there is absolute indications which includes meningitis as well as subarachnoid hemorrhage. From relative indications for lumbar puncture is if there is unexplained coma, if there is GV syndrome, suspected GV syndrome, multiple sclerosis. These are the, as well as there is suspicion of the neurosyphilis. In those conditions, there is relative indications of lumbar puncture needle, as well as in the use of radiology for pneumoencephalography as well as for myelography also. Lumbar puncture can be done, And from the therapeutic indications, to decrease the intracranial pressure in the patients who have hypertensive encephalopathy, as well as to administer the spinal anesthesia and to introduce the drugs.
Yes. Normally, when we talk of drugs, what are the drugs which you usually introduce through the lumbar puncture? Then you would say that sometimes in meningitis, we used to earlier use some antibiotics, but that has been stopped because all the antibiotics which we commonly use for meningitis, they cross the blood-brain barrier. But some chemotherapeutic agents in patients with some malignant diseases, still we use some injection of chemotherapeutic agents through the lumbar puncture. Now, what are the common contraindications for a lumbar puncture? Enumerate them.
Sir, common contraindications for lumbar puncture is if patient has marked spinal deformity.
Yes.
Second is local infection is there.
Yes.
And there is raised intracranial pressure also.
How will you find out that there is raised intracranial pressure and you should desist doing lumbar puncture?
Sir, contraindication for lumbar puncture in the raised intracranial pressure, we can look for fundoscopy, and
Yes.
if there is presence of the papillary edema, then one should not do the lumbar puncture in the patient.
Yes. What do you do then if it is contraindicated? Then you do a cisternal puncture.
Cisternal puncture.
Or do a ventricular puncture. But then those things are required and has to be weighed according to the patient's position. Right. Now, how will you perform a lumbar puncture?
In performing the lumbar puncture, first the patient position should be remembered. The patient should be lie in the lateral position, whether it's right or left lateral position, and patient should be kept at the edge of the bed.
Yes.
And patients by both knees should be drawn up and head should be maximum flexed.
So it is almost in a crawled position.
Yes, sir.
Yes. Then.
And lumbar puncture as well as can be done in the sitting position and leaning forward position also.
Yes.
Site should be, as I told, between L3 L4 vertebrae, and after marking the site, the local site for the lumbar puncture should be sterilized with the cetavolone ether, iodine and spirit, and after that all these sterilization, the site should be draped, and after then after it 5 ml of the 2% lignocaine should be introduced to give the local anesthesia, and then we wait for 2 to 3 minutes, and after 2 to 3 minutes the LP lumbar puncture needle is introduced in the direction, the cutting edge of the bevel should be introduced in the direction of the parallel to the ligamentum flava.
Yes.
And after penetrating the skin, the needle should be slightly upwards as well as forward through the resistance of the supraspinous ligament.
Yes.
And later on it goes through the resistance of the interspinous ligament, and as we reach to the ligamentum flava, and there is a popping sensation when we breach the dura, and as we come to know that dura is breached, then stillage is withdrawn and the cerebrospinal fluid is collected in the amount of 4 to 5 ml, and which is sent for the cytology, biochemistry as well as for other biochemical.
Sometimes it is thick pus, then you might have to introduce a bigger bore needle,
Yes,
or you have to wait for some time to, or you might have to sometime aspirate out by putting in a syringe. Now, what are the difficulties which you can face during a normal lumbar puncture?
So difficulties which are commonly faced during lumbar puncture, first is dry tap, second is blood stent CSF.
Yes, that is very important, because if you have a hemorrhagic CSF, then you are doomed. Your diagnosis suffers. Now, how will you prevent that?
Sir, the commonest cause for dry tap is, first is faulty technique can be there, second is if there are any subarachnoid blockage,
Yes.
and third is if needle is blocked, then we we stillate, withdrawn and then again reinsert,
Yes.
and the with needle which is already blocked, it can be reopened.
Yes.
And the causes of blood stent CSF, first is if there is injury to the spinal blood vessels,
Yes.
second is if patient is having subarachnoid hemorrhage.
Yeah, yes. Then you differentiate the subarachnoid hemorrhage from a hemorrhagic CSF is that when you put in the needle, there is equal color fluid, blood color fluid will come in all the vials which are coming in. But when it is hemorrhagic, then usually it stops after some time.
Yes.
Right. Now, Name some complications of lumbar puncture.
Complications usually immediately after lumbar puncture, patients complaints of headache,
Yes.
back pain also, and later on later complications can be infection, and sometimes if there is increased intracranial pressure, and there can be medullary herniation also.
See, normally you are expected to know the normal contents of the CSF. Now, whenever you do a CSF, you do in a particular situation, say you are doing for a meningitis. Now, you have to differentiate pyogenic from tubercular. How will you do that from the examination of the CSF?
First we can differentiate both of disease. First, the appearance are changed in both. In pyogenic meningitis, the appearance of the cerebrospinal fluid is turbid,
Yes.
and in tubercular meningitis usually the appearance of the CSF is clear, or it can be slightly opaque also.
It is yellowish usually.
Yellowish
Yes,
also.
yes.
Second is increase, there is CSF pressure is increased in both, and blood sugar is also decreased, but comparatively in pyogenic meningitis it is markedly decreased
Yes.
compared to the tubercular meningitis.
What about cells?
What about the cells? In pyogenic meningitis there is predominance of the polymorph cells,
Yes.
and in tubercular meningitis there is predominance of the lymphocytes.
Very good. Now we come to next instrument, say liver biopsy needle. I would invite from the audience if somebody can answer what is liver, how will you identify this needle?
This is liver biopsy needle.
Yes.
It consists of trocar, cannula, and split needles.
Yes. Yes, yes. Go ahead. Go ahead.
Yes, various indication.
Yes. Now, after you identify this, what are the indications for this? Is not only liver biopsy. This can take biopsy from other sources also.
We can use it also in kidney biopsy.
Good. Good. Now, what are the contraindications for liver biopsy? We talk of indications later.
Yes,
Contraindications.
Contraindication is severe hepatocellular jaundice,
Yes.
because hepatic coma may be precipitated.
Yes. Yes.
Bleeding the ashes,
Yes.
infections of the liver and
Yes.
surrounding tissue.
Yes.
These are the various contra.
And what are the indications?
Indication is cirrhosis of the liver,
Mm-hmm.
hepatic malignancies,
Yes.
granulomatous disease of the liver,
Mm.
unexplained fever with hepatomegaly,
Yes.
unexplained jaundice,
Yes.
chronic hepatitis with jaundice,
Yes.
and we can also use it in screening of the patient,
Who's
in
related?
screening of the relative of the patient with familial disease.
And
of
in
the-
all cases where hepatomegaly is there and the origin is not known,
Yes.
right? Now, when we do a liver biopsy, we have to look into certain parameters to avoid complications. What are they?
Sir, we must do bleeding time, clotting time, and prothrombin time.
Yes.
If-
Why prothrombin time is important?
Because the severe bleeding may occur if prothrombin time is prolonged.
Yes.
If prothrombin time is prolonged, we must give intramuscular vitamin K 50 milligram for 3 days.
Yeah.
If not corrected, then fresh frozen plasma must be given to the patient.
But then you have to weigh whether liver biopsy is giving information vis-a-vis the dangers which are there for liver biopsy, right? Now, briefly tell about the technique of the liver biopsy.
Yes. First, pre-anesthetic medicine, we must give atropine 0.6 milligram and phenobarbital 50 milligram IM before the procedure.
Yes.
Then position of the patient. Patient lies on the bed, in the spine position,
Yes.
and right side near the edge of the bed. Then, sir, we give 1% lignocaine as a
To anesthetize locally. Yes.
up to the skin, subcutaneous tissue, and up to the tissue, up to the capsule of the liver.
Right.
Then, sir, trocar and cannula is inserted through the liver parenchyma.
Yes.
Then we remove the trocar
Yes.
and split needle is introduced
Yes.
to cut the
Show me. Yes. 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 Continue.
liver tissue.
Mm-hmm.
Then cannula is rotated.
See, this is how you introduce like this, and there is a trocar inside. When you have introduced in, you remove the trocar, introduce this beveled cutting needle, and you just rotate it. After you rotate it, then you push the needle
Yes.
more inside, so that the piece which is obtained comes into this, and then you remove it.
So,
Then you remove the whole needle
so
simultaneously.
sorry to
You take
interrupt,
a
so
needle.
please repeat because the camera was not focused.
All right, right. This is what is Wim Silverman's liver biopsy needle is there, and we introduce the needle right straight like this with trocar in, and when we put it in, then what we do is we take out the trocar like this and introduce this cutting needle inside, and when this opens up and then we rotate it to obtain a piece of liver tissue inside, then we introduce the needle, little push more inside. When it takes when it the beveled end comes in, then we take out the whole needle. This brings out the tissue, and then tissue is taken and put into the media wherever it is, it can be put. Good. Now name some important complications of liver biopsy.
Complication is, sir, the infection,
Yes,
hemorrhage,
yes,
pain at the local site,
yes.
and sir, in case severe jaundice.
See, doctor, sometimes there is ascites, massive ascites simultaneously, and do a liver biopsy. The difficulty, how will you do that?
First, we must tap the ascites
Yes,
before doing the
yes.
liver biopsy.
Or else you just keep the patient a little more tilted so that the fluid shifts down to the other side, left side, and then you can attempt it. Good, thank you. Sit down. We come to the another important biopsy needle. So this is a kidney biopsy needle. Now I'll say, how do you identify? Will you like to respond, doctor?
So this is a kidney biopsy needle.
Yes. What is its name?
Win Silverman's, true cut needle.
True cut needle, yes. But Wim Silverman needle also
Yeah.
can. In our times, probably we used to do it with Wim Silverman only. But this is a more refined and a better needle, true cut needle for kidney biopsy, right?
Yes.
Okay, go ahead. Now, what are the indications for kidney biopsy?
So there are various diagnostic as well as prognostic indications for kidney biopsy needles.
Yes.
Among diagnostic indications is asymptomatic proteinuria.
Yes.
That is when there is no cause identified and the proteinuria is almost 1 gram per day.
Yes.
Then isolated hematuria.
Yes.
Then infections like acute nephritis, where the obvious cause is not known. Then nephrotic syndrome in adults. Then acute renal failure, where the cause is not known, as well as the renal obstruction is not there, like that the cause is excluded.
Yes.
And chronic renal failure also.
Yes.
Among,
And what are the contraindications for kidney biopsy?
So the contraindications for kidney biopsy is any bleeding diathesis is
Yes.
there.
Yes.
In case of hypernephroma,
Yes.
then acute glomerulonephritis,
Mm-hmm.
if it's like severe, then bleeding single kidney.
Yes. Now, what are the prerequisites for kidney biopsy?
So the prerequisites are, first we have to look for the bleeding time, clotting time and prothrombin time. If it's
Yes.
prolonged, then we have to give vitamin K injections for 3 days,
Mhm.
and we have to look for the prothrombin time later.
And you should assess kidney functions also.
Kidney function.
Urea, creatinine, seeing what is the function of the kidneys already functioning. Right. And how do you, what is the technique of the kidney biopsy, and what are the important precautions do you take before doing a kidney biopsy?
So the technique for the kidney biopsy is, first we have to give the pre-anesthetic medication, that's 0.6 milligram of.
First, I think you should do an ultrasound examination to find out exact position of the kidneys, size of the kidney, placement of the kidney. Sometimes you might be able to get help from the ultrasonologist for getting a kidney biopsy, sometimes difficult situation, okay? All right, go ahead.
So after localizing the site and the shape of size of the kidneys,
Yes.
you have to give the pre-anesthetic medication, that's
Yes.
0.6 milligram of atropine. And
What should be the position of the patient? Should be
so
supine
patient
or
should be laid in the
prone?
prone
Prone
position
position,
with
yes.
pillow below the abdomen.
Yes, yes.
And then we have to, with the help of X-ray abdomen or with the help of IVP, have to localize the kidney.
Yeah.
There we have to do the puncture.
Mhm.
Then the disease site has to be the site for the kidney biopsy. And if it's both sides are involved, then preferably left side is used for the kidney biopsy.
Mhm.
And after that, local anesthesia is given by 1 ml of lignocaine 5%.
Yes.
And after that, kidney biopsy needle is introduced in the.
Can you demonstrate how to do it?
So first we have to introduce the trocar
Yes.
with the cannula inside the tissue where the
Tissue,
kidney
yes.
biopsy
When it
has
embeds
to be
itself
taken.
into the kidney, then
Hanji. Then we have to take out the trocar and put in the bifid needle in this.
Yes, yes.
And rotate the trocar over the bifid needle so that the cut tissue comes inside the needle.
Then you can draw it back.
And then they draw it back.
Right. Any important complications while doing kidney biopsy or immediately after kidney biopsy?
So the very important complication is hematuria
Yes.
and localized pain.
Yeah.
It can lead to hematoma and it can lead to infection. Also.
You have to be careful how long hematuria. I have in my experience seen that hematuria continues for some time, for a longer period, and there is a massive hematuria. And sometimes it's a necessitated use of blood transfusions, and in rare occasion even nephrectomies have been performed. So one has to be very careful under that.
So ideally it should be for 24 to not more than 24 to 48 hours, and that
means you have to be cautious enough for next
after
24 to. Right. Next we talk of bone marrow aspiration. Now bone marrow aspiration needle is a very typical type of needle and is important because we are doing or piercing the bone marrow. We have to see that the aspiration needle is very sharp beveled end so that it can go into the bone easily. Now how to identify this instrument? Dr. Neeraj, will you respond? Yes.
This is a bone marrow aspiration needle. First, because of it is thickened compared to the any lumbar puncture or aspiration needle. Second,
it is smaller in size.
Smaller in the size,
Yes.
and third is it has a guard.
Yes.
So it is a lumbar. It's a bone marrow aspiration needle.
The guard. What is the importance of this guard?
The importance of this guard is to prevent when we are using for bone marrow aspiration, particularly in the from the sternum,
Yes.
and if from using this guard we can prevent the injury to the great vessels
Yes.
during the procedure,
Yes.
as well as
This
sometimes
guard
we
will
have
prevent
constant
this needle
transfixation of
passing through the
sternum.
sternum outside.
Yes, sir.
That is important. Right. What is bone marrow aspiration in fact?
Sir, bone marrow aspiration is a aspiration of bone marrow.
Bone marrow tissue.
Bone marrow tissue from
Bone marrow cells or material
Yes, sir,
or
bone-
bone